Okay, I believe we're now live. So off we go.
Well, good morning, everyone. I hope everyone is well. And I would like to call the Health Connector Board meeting to order. As we know, we have two meetings today. One is the 2021 annual board meeting and agenda, and we will do that one first. And so I'd like to call the annual meeting of the Connector Board to order. So with that, we have one primary duty today of the annual meeting, and that is to elect the vice chair. Is there a motion to elect a vice chair?
So moved.
Oh, and do we have a nominee?
Who is the nominee?
I believe Dr. Turnow, Michael
Yes, I think
Turnow
it's
is
me.
our nominee to continue to serve as our vice chair until we do an annual meeting once a year. So with that, Dimitri, do you move for Michael to continue to serve as vice chair?
So moved.
Is there a second, please?
I'll second.
Great. Is there any discussion about, any further discussion? All right, all those in favor, and I think Kathy, you're going to do this by a roll call, right?
I am. Good morning, everybody. Gary.
Good morning, Kathy. Yes.
Good. Do I ask Michael? No.
Maybe not. Maybe I'll abstain. Whatever's appropriate. I'm honored nevertheless.
Okay.
I'm
Mark.
grateful.
Mark.
Good morning, Kathy. Yes.
Good morning. Okay, Cassandra.
Good morning, yes.
Dimitri.
Morning, Kathy. Yes.
Secretary.
Good morning, everybody. Yes.
Nancy. Yes. Matt.
Yes.
Rena.
Yes.
And I just want to note that Faye, Ruth, and Keisha will not be in attendance today.
All right. The motion carries, and thank you, Michael, for your continuing to serve as vice chair. And then I think, does that close our annual meeting?
I think so. We might need a motion.
Motion.
Yeah, I know. You need a motion to
Second.
close the annual meeting.
Motion to close the annual meeting. Secretary
I'll
Suggs.
second it.
All right. All right, Kathy.
Here we go. Okay, Gary.
Yes.
Michael.
Yes.
Mark.
Yes.
Cassandra.
Yes.
Dimitri.
Yes.
Secretary.
Yes.
Nancy. Yes. Matt.
Yes.
Rena.
Yes.
Thank you, everyone.
Great. Thank you. Thank you. And congratulations, Michael. All right. So it is our annual, let's see, December meeting of the Connector. And the first order of business is, of course, the review of the minutes from October. So is there a motion to accept the minutes?
Motion to accept.
Is there a second?
Second.
Thank you. All right, Kathy.
Okay, Gary.
Kathy, I'll just abstain because I wasn't here last time.
Okay, Michael.
Yes.
Mark.
Yes.
Cassandra.
Yes.
Dimitri.
Yes.
Secretary.
Yes.
Nancy. Nancy.
I said yes.
Oh, I didn't hear. I'm sorry.
Sorry.
Matt.
Yes.
Rena.
Yes.
Thank you, everyone.
Thank you. All right. So there's a lot to report on, and we have a lot to discuss on the strategic plan updates today, of course. But let me first turn it over to Louis for the executive director's report. And it's good to see everyone virtually.
Thank you. Thank you, Secretary. Good morning, all. Today's main meeting agenda addresses strategic planning in two important areas: our work to make access to coverage equitable and our pursuit of additional measures to cover the uninsured. We remain firmly committed to providing access to quality health care to Massachusetts residents who need coverage and reducing barriers that remain for residents and communities across the state to gaining that coverage. Today's discussion will detail our work to date in both of these areas and also define our next anticipated steps around equity and effectively reaching those who remain without coverage. Before we get into the strategic topics today, I do want to provide an operational update. We had a rocky start to our new call center services in October, partly technology driven, which we were aware of in the last board meeting, and also because of a large attrition rate of the initial classes of contact center service representatives. And since talking with other exchange directors, it's really quite a phenomenon this year. It's a very fluid labor market, and attrition rates in sister exchanges have been really quite shocking. But I am pleased to report that in recent weeks, the call center has found its footing and is now posting service levels better than we've seen in years, with abandonment rates regularly under 3% during open enrollment and satisfaction rates approaching 80+%. We are working on continued improvement in satisfaction with a goal of 90% satisfied and very satisfied, and continue to work with the vendor on reducing an accumulated backlog of documents to be processed and so-called tier 2 or more complex member operations. But we are optimistic that we are on a sound path to highly responsive customer service. With the call center stabilizing, we are quickly coming up on our important December 23rd billing deadline for January enrollment.
Louis, may I just interrupt for 1 second?
Yes.
So to the board, to other board members, the staff have been working extraordinarily hard with Accenture, the provider, the vendor, to right the ship, if you would. I joined a meeting with Louis and the executive team with the highest levels of Accenture, I want to say a week ago, to convey from the board our expectation that customer service is clearly our focus, and they made very clear commitments of to do everything possible to address the fundamental issues. They accepted responsibility. There was no deflection of issues, and that they are putting in the resources regardless of what the cost is to the company and the service. We're going to have another follow-up next month, just because it's sort of who I am, to support Louis and his executive team and on behalf of the board. But I actually felt that we've had their attention, but I really wanted to convey how important it was to all of us, and that customer service has been such a cornerstone of the connector. So that's my 2 cents on this, Louis.
Thank you, Secretary. And it was a very helpful meeting. We really appreciate that. With the call center stabilizing, we are quickly coming up on our important December 23rd billing deadline for January enrollment. That's 2 weeks from today. Next week on Monday, we are opening our Boston Walk-In Center, and later in the week, Springfield. Worcester will reopen in January. These walk-ins have been closed since March of 2020 due to the pandemic. And they are one key element of our offering to ease service for members and applicants in an in-person option for securing enrollment, dropping off a payment, and we are pleased to begin offering this option to members again. We have largely completed auto enrollment for our members, with more than 256,000 members enrolled for 2022 in qualified health plans. Our new enrollments are somewhat below average, which we believe is a continuing result of Medicaid protections through the federal public health emergency. We do anticipate that thousands of people will become eligible for Health Connector coverage when the emergency ends, and we are doing intensive planning with MassHealth, the federal government, and others for a comprehensive effort to maintain coverage for as many of these people as we can. Additionally, this winter, thanks to new legislative language included in the governor's FY22 budget, we will start our new partnership with the State Department of Revenue, receiving information from uninsured taxpayers who choose to check a box on their tax forms asking to be contacted by the Health Connector with coverage options. We have been working with DOR to start receiving information this next spring and developing a direct communications plan that will make enrollment as easy as possible for these uninsured residents. And all of this put together means we are planning on a very busy 2022. And I do want to end with hints of good news. According to data from the US Census and CHIA, the Center for Health Information and Analytics locally, it appears that more people in Massachusetts may have health insurance now than ever before. The US Census announced last week that the uninsured rate in Massachusetts is 2.6%, the lowest in the country again, and lower than the previous estimate of 3%. CHIA estimates that the number of covered residents has increased 1.5% over the span of the pandemic. COVID colors both of these numbers. The census survey was limited due to pandemic restrictions, and the CHIA data reflects increases in public coverage. But in the end, both survey and administrative data on coverage in Massachusetts are positive, which gives us a fresh opportunity to hold the line on coverage gains and go even further. And with that, I am happy to take any questions or allow the meeting to proceed to its main agenda items.
Thank you, Louis. Let me just open it up to the board. Any comments, questions, thoughts? Anybody? No? All right. All right. Well, then let's go into the heart of the meat of the agenda.
Great.
And Audrey, the only thing I'd say is there's a lot of data in here. So, you know, to pause every once in a while so folks can weigh in. Okay.
Absolutely. Sounds good. Thank you, Secretary. Good morning, Secretary and members of the board. Today, we'll be providing an overview of the work we are engaged in to prioritize health equity with an eye towards leveraging to the fullest extent our role as the state's health insurance marketplace and the tools and levers we have. As a guiding principle, we're thinking about the full range of experiences our members and the public we serve have when they enter and experience Health Connector coverage, and the range of policy and program tools we can use to prioritize health equity. Staff are approaching all aspects of equity work with resolve and also a posture of humility and curiosity. We know we will continue to learn and challenge ourselves on matters of equity and better understanding the needs of populations who may experience barriers to the health and financial protection that our mission intends to connect all Massachusetts residents with. For that reason, we expect the Connector's equity work will be iterative and reflect those ongoing learnings, as well as perspectives from you, our board, members, the public, and other state and community partners focusing on health equity. Specifically today, we'll walk through 4 major categories of our work that we've taken steps to braid an equity focus into. 1, the outreach, marketing, and community presence work we do to reach and bring Massachusetts residents into the ranks of the insured and into Health Connector coverage. 2, the experience of people who get into our coverage, including determining whether there are inequitable administrative burdens and time taxes involved in maintaining coverage and getting member needs met around keeping coverage. We're seeking to understand and address administrative burdens that may fall most heavily on populations who have less language access, capital, and time to surmount them, resulting in higher uninsurance rates, gaps in coverage, or general member abrasion. 3, the equity dimensions of the covered benefits itself that we offer to members, and work we are engaged in to reduce inequitable barriers to care for all members, especially for conditions disproportionately borne by communities of color and other populations with health disparities. Lastly, a focus on improving our access to data on race, ethnicity, language, sexual orientation, and gender identity so that we, along with the partners with whom we work, can ensure that our strategies to advance health equity are driven by data and a strong understanding of our membership and the coverage landscape in which we operate. For each of these 4 categories, we'll briefly note our focus and highlight activities from the past year, as well as those actions we've teed up for 2022. The first section that we'll cover is on the continued gaps we see in health coverage rates among different racial and ethnic groups here in Massachusetts. These disparities have been a long-standing focus for the Health Connector as the state's marketplace, and in the work we do to heighten awareness about health coverage, the requirement to carry it in Massachusetts, and serving as a doorway to coverage to residents who don't get it already through work or another program. Since the passage of Chapter 58 of the Acts of 2006 and the Affordable Care Act in 2014, we've seen material increases in the coverage rates of Massachusetts residents across the board, including in communities of color. But the disparities do remain, with Latino and Black populations and other communities of color lagging behind the health coverage rates of white residents. For this reason, we've intensified our focus on new additional steps we can take to bring people into coverage. For example, we're actively exploring ways we can broaden our community presence around the state through our Navigator program or other formal collaborations with a broader array of community-based organizations that have close ties to and credibility with the populations we're focused on reaching and covering. We continue to focus on prioritizing ethnic media outlets, multilingual resource availability, and earned media, call-in programs, and local leaders, with an eye towards placing our messaging about coverage where the communities we most need to reach get and trust information. We're also thinking about how we use not just our individual market coverage and market presence to reach historically underserved communities and draw them into coverage, but also how we can use Health Connector for Business to make small group coverage even more accessible and equity focused for small businesses and communities of color and other populations that have faced barriers historically to health coverage. Here are just a few illustrative examples of how our heightened equity focus is manifesting in our outreach work. This past year, we developed press releases and press strategies that specifically linked new affordability help from the American Rescue Plan to coverage disparities in specific populations, a strategy we are using again during this open enrollment period. In July, we procured a new Navigator arrangement specifically to address a gap in in-person community presence in our Navigator program that we'd identified in Lowell, which is the 5th largest city in Massachusetts and has a high percentage of residents of color of about 40%, notably driven by Southeast Asian populations. To make coverage information and enrollment assistance more available, we're partnering with the Lowell Community Health Center and ask them to partner with the Cambodian Mutual Assistance Association to help us make deeper inroads into the Cambodian and Southeast Asian populations in the city of Lowell. We're hoping to leverage this exciting new model of Navigator and other, perhaps smaller and more specialized community groups in our next Navigator cycle procurement process this coming spring. We're also actively engaging our Navigator network to explore their thoughts and get their thoughts on tools and resources they need to make stronger inroads into the populations in their communities, whether that's additional support on translation services or more centralized data on race and ethnicity and coverage gaps in their communities so that they can use it to shape on-the-ground strategies. We're taking steps to respond to this feedback. On the Health Connector for Business front, we're pleased to have recently launched a new partnership with the Massachusetts LGBT Chamber of Commerce and are planning steps in early 2022 to explore more partnerships with a broader array of small business organizations, including small business owners in communities of color and immigrant communities. Now that we've walked through—
Audrey, can I ask a question?
Of course.
How are we going to evaluate those activities to see how we do and what we learn?
It's a great question. It would certainly welcome thoughts from the board. I think there are metrics we can look to from a process perspective in terms of how many new partnerships we're able to establish. I also think looking at how those partnerships drive enrollments compared to our kind of broader efforts could be helpful, just to see if our hypothesis is true that some of those more tailored partnerships could surpass what happens when we kind of do a broader brush approach, but would certainly welcome thoughts from you or others on the board.
I'd be happy to talk to you offline. I do think all those efforts look wonderful and exciting. And I just think it's, as I know you and others do, that we really understand what works and why and what doesn't. So,
Nancy, that's a great question. Analogous to, in some ways, as we've rolled out vaccines in the Commonwealth, and particularly in what we refer to the vaccine equity initiative, and 20 of the most disproportionately impacted communities, and they're disproportionately represented by individuals of color in Massachusetts. There are lessons. It is I refer to it as a vaccine canvassing campaign with very, very grassroots, and we established metrics and we publish metrics weekly. That's vaccine, so I'm not sure that's quite analogous, but put the data out so everyone can see it and learn. And I think there are some lessons, and one of them is working with faith-based community organizations that are truly rooted in community, and not necessarily work in community, if you know what I mean. Like, it's one thing to have like a service site in a community. It's another thing to really true grassroots. And I would encourage you to have some metrics, whether it's like whatever the insurance rate is in that community, or you break it out by population, and that you measure it, and not just a process.
I think the analogy to what's been going on vaccination, I think is very good. And I think we have in other kinds of services and supports, I think, experience in literature, and you'd be much more familiar given, your long and illustrious career, Secretary, and many of
my long and illustrious career.
Yeah, well, but I think it's important, obviously, just for our own efforts, but I think more and more states, we hope, and we've been joined by a number of other states that have gotten to, kind of 3-4% uninsured. This last 3 to 4%, is clearly really, really challenging. And even if we look at other countries that have universal systems that rely somewhat on voluntary action, they end up with 2, 3, 4% of people not covered. So I think our evaluation on this end would serve not only our own state, but I think would really help other states who are making progress, and they're going to, hit a little bit the same wall that or ceiling or whatever it is that we have,
or an opportunity not yet realized.
Yes. Okay. Well, that's why you're in the political realm, Secretary. So.
To me, this is a great opportunity, great challenge, right?
Yeah. Oh no, I think it is, and it's one we've had now for 15 years.
I know.
So yeah.
So I applaud this. Sorry.
No, thank you, and thank you for the question. And transparency and reporting and evaluation are going to be key hallmarks of how we progress with this work, so we can iterate and improve as we go. Okay, thank you. So now that we have walked through how we're centering equity in our outreach work, I'll hand it over now to Nelson, who will provide an overview of our next area of focus on how we're seeking to advance health equity by removing barriers and points of abrasion where possible in the member experience of people and populations we bring into coverage.
Thank you, Audrey. So there are many abrasion points and administrative burdens associated with the process of applying for, enrolling in, and maintaining coverage with Health Connector. We know from our escalations that some of the pain points include enrollment issues for things like retro enrollments and reinstatements, billing and payment issues for things like payment transfers and refunds, requests for information and document processing. So when individuals need to provide proof of something like income, duplicate HICS applications, and technical issues. While some of these features and processes may be required by law, some may still be adjustable. And in addition to improving the overall member experience, we're focusing on these pain points because they can also become barriers to coverage for populations that have the least time, resources, capital to navigate them, and for example, time constraints, reduced web access, language barriers. And one of the things that happens is for each additional step or barrier in the process is known as a voltage drop, where it becomes harder for a person to proceed to enrollment, and they kind of lose that momentum from the point of when they decide that they want coverage and when they're ultimately able to secure that coverage. So part of what we're doing is looking within to see what are some of the barriers that we can lift or alleviate to help the member population that we're most trying to get into coverage do so and keep coverage. And a recent example of where we've been able to do that is after some internal review of our escalations and member pain points, we identified changes that we could make to our retro enrollment and reinstatement policies that would allow the contact center to easily or more flexibility to get members back into coverage if they experience the loss of coverage for something like non-payment of premium or loss of coverage as a result of an RFI expiration if they fail to submit documentation on time. So, and we're also exploring additional opportunities to work with the federal government as they've also focused on reducing administrative burdens, and we see that as an opportunity to collaborate in the future. All right, and then as far as some additional work in progress for helping individuals get covered and stay covered, we conducted a review of our demographic data of our escalated cases, which identified a higher proportion of them coming from white English-speaking individuals, which is not representative of our overall population and may suggest that some of the channels that we have in place are less available to some communities. And also we're exploring automatic enrollment for people who are eligible for $0 plans, but don't select it. So if they aren't able to make a plan selection on their own, maybe we have to help them out. And some details on that will come up in a later presentation today. And then some of the items as far as what's next on the horizon for 2022 include conducting an audit of the burdens related to our excessive and confusing notices and the various paperwork requirements, like for example, the RFI proof that individuals need to submit, for things like income or citizenship. Are there opportunities for us to streamline that process? We're also planning to implement a simple sign-up program, and this is something that will also be detailed further in a presentation later today. And also related to the escalations demographic data that I mentioned, making sure that going forward we have culturally competent channels available for members to get help when they need it, which ties into some of the community-based focus that Audrey mentioned earlier.
Hi, Nelson, quick question for you. This is Dimitri. I'm trying to figure out if I heard you correctly. You mentioned some of the abrasion or obstacles in terms of obtaining coverage and maintaining coverage seems to be more prevalent in the population where English is their native tongue, so to speak. Was that accurate, or?
No, I think really the finding there is that more of the people who escalate with the channels that we have available now happen to be people who are white English speaking. We don't believe that they're the only ones who are experiencing these challenges. So that's part of why we need to make sure we have more options available to people to get the help that they need in the way that works for them. So being in coming back to the community presence and helping people where they live.
So given the complexity faced by those who are native speakers, is there a new strategy that's being put forth to ensure that those who English is not the native tongue have the ability to obtain the assistance or that they need, or to properly navigate the system? Better yet, we know within the immigrant population, education level may also be an issue with some of the folks that are trying to navigate that process. Do we have any data there, or is that something that you all will be looking at in the future?
Yeah, that's exactly the things that we want to focus on, and exactly the challenges that you described of why we think some of those individuals aren't reaching out and getting the help that they need. We do think they're experiencing the same challenges, but may not be comfortable or have the resources or the access or know how to escalate their issue and get the help that they need. So we do need to have more of a presence and availability in those areas with those, where people can get help in the language of their preference or with some of their trusted partners in their communities, and have that make its way to us so we can help equitably across all of our member base.
Nelson, so this is terrific. I want to push, or not ask is a better word, a little bit more about the partners in the community. I obviously care a ton about coverage, but honestly, maybe even more so, I care a lot about access to care, and people are getting the care that they need, particularly people that may have chronic conditions or have other particular health needs. And the hope is not to have them forego those needs. In the partners in community bucket, does that include some of the providers, places where some people may end up if they have healthcare needs, but they've lost their coverage in varying ways? So there might be some places where these people go to get care on a regular basis. And if we understood where those were, we might have touch points to have those organizations help their patients remain our members. So I don't know if we consider them partners as well, but it is a place where at least I think some people with chronic conditions may appear and may help us make sure we don't miss those with particular needs. Although, of course, my worry is that people with those needs aren't actually getting to those places. But to the extent that some of them are, it might be a way to help them stay with us.
Yeah, no, I think that's great feedback, and yeah, absolutely something that we need to explore. All right, and as far as ensuring, along the same lines of this conversation, we need to ensure that we have our member services are equitably accessible and helpful to all groups, regardless of the channel that they choose, whether they're looking for in-person assistance, assistance over the phone or online. And then some of the highlights of work that's in progress include translation of our HIC system into Spanish, and that's something that we are currently evaluating to establish kind of the usage of that given the change. And then also receiving feedback from our navigators to inform translation of materials into other languages, and making upgrades to ensure that our content on the CCA website is accessible to visually impaired populations. And some highlights of things that are coming up next in 2022, including a full reevaluation of how our individuals interact with us, enrollees, applicants, and general public. How do they interact with us and experience the Health Connector services, including the physical community presence, but also the phone and the virtual experience. And lastly, we're planning a equity audit of our member services functions to identify, are there additional opportunities for us to change how we serve members with the focus on equity. So I'll pause there if there's any additional questions. If not, I will hand off to Maria, who will take us to the next section.
So I just want to commend you for doing an audit on who uses the escalation processes to determine whether there in fact could be some the disparities sort of show up in terms of who actually has connector insurance, connector products and the like. So I think that is it's a good thing to do, right? And to then figure out if there's barriers that others are not using and why they're not using, and then doing the root cause analysis. So it takes time to work that through, but it's the right thing to do, Nelson. So I just want to acknowledge that.
Thank you.
All right.
Hi, thank you and good morning. As part of the Health Connectors equity work, policy and plan management staff are focusing on ways to address inequities related to cost sharing, benefit and formulary design, and provider network access. Cost sharing is a barrier to care that disproportionately impacts communities of color, and staff are exploring ways to alleviate cost sharing burdens for high value services and in standard plan design more generally. To date, staff have reduced cost sharing for insulin, and we're expanding our understanding of the research and needs in this area to inform the next seal of approval cycle and beyond, particularly for the Connector Care program. Additionally, to supplement existing survey research on the impact of cost sharing on access to health services, we will conduct member interviews to gather a deeper perspective on the biggest cost challenges facing members. Staff are also working in partnership with other state agencies to support efforts to improve maternal health outcomes and behavioral health care access. So speaking a bit to provider network access, compared to the initial launch of the Connector Care program, Connector Care members have a choice of fewer carriers and narrower networks, a pattern of particular concern since communities of color represent a larger share of Connector Care membership than in other market segments. In 2022, the Health Connector took steps to reduce the enrollee premiums required to access broader networks and is continuing to explore and seek feedback from stakeholders and the public about how to address inequities in provider access going forward. And in recent years, the Health Connector has prioritized bolstering its proficiency in the area of benefit and formulary design review, with a focus on cost sharing and formulary tiering that disproportionately burdens individuals with chronic conditions. These efforts have included use of CMS's formulary review tools by those with clinical expertise to identify possible areas of concern and responsive seal of approval requirements. The Health Connector is continuing to partner with the Division of Insurance on these iterative efforts and working with carriers where needed prior to developing policy changes. And as the Health Connector brings together nearly all commercial carriers operating in Massachusetts, we are uniquely positioned to facilitate discussion and alignment across carriers in understanding and advancing health equity activities in the market. Building on information collected during the 2022 seal of approval process, staff are exploring ways to build upon the ideas and responses received, and we are in regular conversation with other state exchanges, such as Covered California, that are at the forefront of leveraging their plan certification processes to advance equity efforts. So that is kind of the waterfront of the efforts that we are making to improve coverage once we ensure that members have gained access to it. And I will pause there before turning over to Marissa to talk about the data collection piece.
Maria?
Yeah.
Hi, sorry. That's terrific. This is an area that I have thought a lot about for a long time, and I commend you on it. One of the complexities that I'd like to ask about is the role that the actuarial value calculator plays in constraining what we can do. Because obviously the goal here is to make sure that people have not just coverage, but they have access. They do not have financial barriers to the care that we really want that coverage to facilitate, which is what you're doing here. So I don't know if I can switch to my hand raised to a clap, but clap. I'm happy you're doing that. The concern is always that when you make coverage for those things more generous, it may or may not get, thank you, Secretary. It may or may not get picked up in the actuarial value calculator, or you may be forced to raise cost sharing somewhere else. And that's always a trade-off. And I don't know how much of a barrier that is. And if we have to worry about the interplay between these efforts and the actuarial value limits that we're bound by.
Sure. No, thanks, Dr. Cherno. I would say absolutely. It's something that we definitely consider whenever we float, any policy idea. I would say a couple of things. One is that we are cognizant of the fact that we generally design our standard plan designs at the very top of the actuarial value range. And that's intentional, to make sure that the plans are as generous as possible. But we know that we need to balance that with saving a little bit of room to fit in some of these VBID type ideas to make sure that they can actually be feasible within the required, plan ranges. So we do try to make sure we leave a little bit of room, and kind of Edith, our actuary, does some preliminary analysis with each idea to sort of get a sense of just how much space might be needed for each idea. So that's definitely a challenge and a trade-off. I would just add a couple of other quick things. One is that on one of the slides, I think we mentioned that for some of these ideas, we're thinking of reducing the cost sharing within the connector care program, which is a little bit different. We don't have the same actuarial value challenges there if we decide to go that route and reduce cost sharing for that population. So I would say absolutely, we welcome your feedback and ideas as we sort of wrestle with that trade-off, but that's definitely something we take into consideration.
Can we go, I'm sorry, I don't want to interrupt if there's more discussion on this. Go ahead, Michael.
No, I was just saying thank you, mutedly.
Thank you.
Can we go back to the slide about narrow networks and access? There a concern overall diminution of network breadth and provider access.
So one of the measures taken this year for the 2021 plan year was to enhance our premium stabilization activities so broader network plans were more affordable to our connector care membership. So that's the kind of thing we've already addressed, but we want to look at additional measures to make broader network plans more available to our membership.
Okay, understood. Thank you.
All right. Nancy?
Yeah, thank you, Secretary. So Maria, I'm so psyched about this. I think that it's very exciting to begin to look at some of these longstanding issues as equity issues. I think that is exactly the right frame. And in particular, I think that the fact that increasingly people who have low incomes are in both plans and have access to provider networks that are separate and not equal is a deeply troubling issue from an equity perspective. The fact that certain carriers have been able to essentially extract themselves from markets that serve people who have lower incomes has been going on a long time, but it's not an attractive feature of the market in our state or in virtually any other state. So I think this is both very exciting work and really important work to do, and love to help you in any way think through how do we redress these couple of features, again, that are not specific to our state, but I think are truly equity issues at their core.
Secretary,
Right.
this is Gary. If I could just momentarily.
Go ahead, Gary.
Yeah, thank you. There near the end, I think Nancy made a really good point about it, particularly in the equity issue not being particular to any one state. I would just say at the outset as well, to Louis and Audrey and the Connector team, thank you for their efforts on the equity front. This is certainly a shared priority at the division. For those that may be unaware, last summer, the NAIC, that's the National Association of Insurance Commissioners, created a special executive level committee on race and insurance, which is the first of its kind in NAIC history. And that special committee has 5 different work streams. I would just highlight the last 3 work streams, 3, 4, and 5, which are charged with examining the things that we're talking about, practices and barriers that potentially disadvantage people of color and or historically underrepresented groups in all lines of insurance, so property, casualty, life annuities, but in health insurance as well. The work streams have been active this year with regular calls, gathering data from the industry, from members of the NAIC and other stakeholders. And I would say notably on that work stream 5, which is focused on health insurance, has been working on a principles for data collection document, which is intended to establish a consistent high-level guiding principles for the collection and treatment of data on race, ethnicity, other demographic characteristics in health insurance. And we recently discussed the comments that were received on the principles document during a meeting on November 18th. And we plan to hold additional meetings to continue discussing the comments on revising the principles. This, I would say this work will clearly help inform our discussions that we have with the connector and the work that they continue to do. So we appreciate you guys leading on this front and your partnership with us. Thanks, Secretary.
Thank you. Thank you. All right. Anyone else? Thank you.
Okay. All right. I think we're over to Marissa now.
Great, thank you. Good morning, everyone. And I think building on Commissioner Anderson's timely comments there, last but not least, we know that to really make progress on our equity agenda, we need to have better data. We've been working with Mass Health on ways that we can improve and expand our data collection within our shared application. Race and ethnicity questions must be optional according to federal rules, but next week we'll add some revised explanatory text to let applicants know why we're collecting race and ethnicity information and encouraging them to provide it. We'll also add a choose not to answer response option so that we can better understand whether data is unknown or whether the member has declined to provide it. And we'll add explanatory text around preferred written language to let applicants know that notices are currently only available in English and Spanish, just so that they're clear on that. Additionally, Mass Health recently issued a request for information from stakeholders seeking feedback on potential structural improvements to the collection of equity-related data. That would include exploration of new questions on sexual orientation and gender identity, and we're eager to hear what they learned from that process. Our work group has also been investigating broader data standards used market-wide by issuers and providers to understand how HIPAA data may work within those frameworks. And we plan to pursue additional application changes over the next year or so, informed by all of this work.
So just to recap what we've walked through, I'm resharing the framework of our areas of equity focus. And as we wrap up, we very much welcome feedback from the board on this framework, as well as any other dimensions of health equity that you think the Health Connector may be well positioned to help press forward on.
So can you just go back to that slide?
Yes.
So my only, first of all, right direction is that we can actually operationalize all of this. And I mean, this will all go into a work plan, I'm sure, with timelines and the like, is that we just, it's all the right things to do. It also is incorporating this with all the work that is going on and keeping this very focused. But I just always feel the need to always just remind folks, once we make this, when we make these commitments, we need to make sure we have the bandwidth to follow through on.
Absolutely. Thank you.
I'm sounding less like a chair of a board and more probably as an agency head. Sorry.
No, very appropriate. No, we have to do, yeah.
Audrey, if I could also,
go ahead, Nancy.
Just add at a couple parts, you and colleagues mentioned learning from what's going on in other states and mentioning specifically California in a couple of these. I do think that there are a few states, particularly on the, what I've come to think of as carrier redlining of poor people, that there are policy approaches that have been suggested or, been implemented in maybe one or two cases that I think we could learn from. I know we always looked at other states, but there are a few that we probably have some good, we can steal some good ideas from.
That's great. Thank you, Nancy.
If I can make a quick comment here on this slide, I've been kind of mulling this issue over during the presentation. So on the right-hand side in our current and planned work, that third cell down, the third bullet, monitoring and mitigating discriminatory plan designs. That's a strong phrase, and I'm interested to hear a little bit more about what discriminatory plan designs means to us.
Absolutely. So this is when Maria was presenting about talking about deepening our, as a staff, ability to keep an eye on design of formulary or benefits that might run afoul of federal rules around non-discrimination protections and benefits. So this is part of the Affordable Care Act, 1557, section 1557, that basically creates tools to make sure that the way a plan's benefits are designed or a formulary is constructed doesn't inadvertently discriminate against a person with, let's say, HIV or a particular health condition. So this is something DOI takes the lead on, and we're very appreciative of their partnership and leadership and sort of domain in this space. But to the extent the connector is designing particular plans and engaging with carriers on behalf of our membership, it's an area we just want to deepen our own appreciation for how to keep an eye out for issues like that may be inadvertent, but there's now a federal framework that gives us tools to make sure that's not happening to our members.
Okay, yeah, that's really helpful. Thank you. So it's really it's a regulatory compliance, and that of course has at its core a fairness and justice element to it. I understand what you're saying there. Thank you.
No, thank you for the clarifying question.
Yeah, and Matt, in the HIV area, for example, Audrey is much less cynical than I, but there's a lot of analysis and evidence, some of it done by colleagues at Harvard, of a deliberate design of formularies in a way that discourages people with certain conditions from joining plans. And HIV is one area, but there are actually a number of others. So I think they're very sophisticated tools now to be able to try to detect that, whether it's intentional or inadvertent.
So I may be swimming upstream on this a little bit. And as it relates to network design, and in particular, the option of narrow network products in the context of an equity frame, I want us to be thoughtful about how we think about that here, because narrow networks by themselves are not inferior to a full network plan just by virtue of that fact. If, as a result of the subsidy structures here, however, we have members who are gravitating to narrow network plans, but it's essentially the same member share, then that's an issue. But if we're offering narrow network plans as an option here that has some financial benefit through lower cost to members, then that is not, and we see certain groups gravitating to those plans. I don't see that as necessarily an equity issue. I see that as people gravitating to a different value proposition for plans. So I think it's worth just sort of reminding ourselves that narrow networks are terrific. Broad networks are terrific. Narrow networks are sufficient and offer excellent coverage. The Division of Insurance and the connector evaluate access standards in those plans. And to the degree that consumers use them, and in particular consumers in the merged market use them, they lower overall costs because we have members using lower cost facilities by virtue of just the plan design and the network design. So I want to just sort of keep that in mind as we think about narrow networks in the context of the equity agenda.
Yeah, we have no fundamental position against narrow networks per se. I think the issue is that
our connector care population is almost very largely forced into narrow network designs by virtue of carrier carrier coverage and carrier offerings. And so the issue of broader carrier participation, the issue of some interventions in terms of premium stabilization efforts to make broader network plans available to our lower income populations. You know, not everything costs the same. Cost differences should be reflected. But I do think we're at risk of having a very two-tier system. And that's the problem. You know, it's not, you know, narrow networks serve a great purpose, but they shouldn't be the only option for our lower income and diverse ethnicity populations.
Rena?
Yeah, I just want to totally agree with what Matt just said. I think that the phraseology that's used in these discussions implies that narrow networks are inferior, and they are not. And I also think we have to be realistic. Broader networks cost more money. They cost more money because there's more choice, and they cost more money because the really, really expensive providers across the state are included in those. And unless we're going to deal with the cost issues, we are still facing a situation where we've got a cost that doesn't align with an aspiration for the type of product that we want to make available to this population. And I don't think we should fool ourselves into thinking that if we try to push the broader network carriers to make offerings in the Commonwealth care in the subsidized population, they're going to offer narrow networks too, because they can't afford to bid a full network product for this population. So for me, it all keeps coming back to the underlying cost, and we keep trying to find ways to band-aid over the cost and push the balloon, but we're not addressing the fundamental problems that make it inequitable, as people have stated.
Yeah, and I thank you, Rena, for that. And I would just say narrow network products and tiered network products are really important to the connector's strategy of addressing underlying cost. If you took those out, and I'm not suggesting you are, and Louis, I appreciate your clarification that we run the risk of a two-tiered system here, which I think does clearly raise some equity issues. But if narrow networks are among the few tools that the connector can use to address the underlying costs, then I would be wary of undermining those because it moves us in the wrong direction.
Anyone else? Nancy?
Yeah, just to say, I don't think we run the risk of having a two-tier system. I think we should acknowledge that we, to considerable extent, have a two-tier system that we have for the reasons that you all articulated, and perhaps others. Created products and carrier participation that now systematically makes it impossible or almost impossible for parts of the market to access certain providers or certain services offered by certain providers. And that this is an equity issue at its heart. And if we are serious about addressing health equity, and we obviously can't address it by ourselves, and we have a certain number of things we can use, and we obviously would have to collaborate with lots of other people around all of the macro issues, but it is an equity issue. at its core. And one could argue that people who have low incomes and a disproportionate burden of all of life's challenges, including disease, actually should have access to a broader network of providers and with transportation issues and other things. So I really applaud that this is on the agenda. And I think we should be very clear-eyed and really honest when we talk about the system that exists at the moment.
Anyone else want to weigh in at this moment? Rena, your hand's still up. I'm assuming you just haven't taken it down. Okay, just, all right.
Okay.
Oh, lot to discuss. Okay.
Thank you. Okay, I think we can stop there. We have kind of a wrap-up slide, but I think we've touched on a lot of the looking forward pieces here. But certainly want to continue to engage the board on all these topics and really appreciate the robust discussion and feedback today. Okay.
I just want to acknowledge Michael has to sign off due to a conflict, and thank you, Michael, for your participation. All right, so we have time. Oh, here we go. We ready to move on here?
I think so. Okay.
Everybody needs to take a pause as we move to this next. We're ready?
We're ready.
All right, we're ready.
Okay. Hello again. For this presentation, I'll be joined by Nikita and Marissa, and our goal is to share with the board an overview of the work the Health Connector is engaged in and has planned to cover more of the remaining uninsured in Massachusetts. Many of the themes you'll hear in this presentation are consistent with our equity focus that you just heard about, given that a disproportionate number of the uninsured are in communities of color or other historically underserved communities. Our presentation will include a refreshed overview of what we know about the remaining uninsured, demographics, barriers, and what the uninsured appear to be eligible for in terms of coverage. We'll also touch on our current approach to outreach and to the remaining uninsured and keeping people retained in coverage, and what we found to be best practices on these fronts. But then, as you'll hear, we'll share our observation that outreach alone may not be fully sufficient to making further inroads into the uninsured, and that new additive approaches to supplement outreach may be warranted. In this vein, we're hoping to share updates on a new initiative we're standing up this spring that will leverage the individual mandate tax filing process to enhance our ability to assist the uninsured into coverage. This new step forward for us is a result of a legislative change this last summer. We also look forward to briefing you on additional tools under exploration by staff that could streamline enrollment processes and reduce member abrasion that can knock people out of coverage and expose them to unintentional insurance gaps. Across the spectrum, from making sure our outreach is evidence-based, effective, and keeping pace with how our population is best reached, to the new tools and approaches we're pursuing, our overarching goal is we want to make it easier to get people into coverage and easier for them to stay there, with a special eye on populations for whom this goal has been more elusive as a result of structural barriers. With that, I will hand it over to Nikita for the first part of our presentation on who the uninsured are and on outreach.
Morning, everyone. Can you all hear me?
Yes.
Great. So as Audrey mentioned, I'll begin today's presentation by sharing what we know about the remaining uninsured and evolving coverage trends in Massachusetts. And then I'll share some information about the Health Connector's current outreach work to draw more state residents into coverage and highlight some areas where additional attention might be required. Please feel free to stop me if you have any questions. So the Commonwealth's 97% coverage rate can be attributed to the state's successful history of health reform, which created long-lasting changes to the health insurance market. For the past several years, Massachusetts has had one of the lowest rates of uninsurance among residents across the country. According to CCA'S health insurance survey in 2019, only 2.9% of Massachusetts residents were without health coverage. While there are many data sources reporting on health insurance status, and we do look at all of them, including the US Census Bureau's American Community Survey, which is represented by the purple line on the chart on this slide. The Health Connector relies on CCA'S data to craft our outreach approaches as it is more tailored to the state's population. As demonstrated in the figure, the state experienced substantial increases in coverage due to expansions put forth by Chapter 58 and the Affordable Care Act. More recently, coverage rates have held steady, keeping up with state population growth, but consistently leaving roughly 200,000 Massachusetts residents uninsured each year. As Lewis noted in his remarks, recently published experimental estimates from the American Community Survey indicate that more Massachusetts residents were covered in 2020 than in prior years. I do want to note that the Census Bureau published this data with several caveats, specifically noting significant non-response bias, where respondents were more likely to have higher annual income and be more highly educated than non-respondents. So moving to the next slide, we have years of state and national level research on the uninsured that has found that the people who are most likely to go without health insurance include non-elderly adults, men, residents who are Hispanic or African American, and those who earn below 300% of the federal poverty level. These trends continue to hold true in Massachusetts, but we're seeing that both survey and administrative data show disparities in health coverage widening, disproportionately impacting more vulnerable state residents. Among uninsured people, the cost of coverage is the most frequently cited barrier to getting insured. Other barriers include fluctuating eligibility, leading to transitions between insurance programs, administrative complexities in the application and enrollment process, and existing policy obstacles such as the family glitch. Though affordability is the predominant concern among the uninsured, with 4 in 5 reporting being uninsured due to the high cost of coverage, approximately 60% appear to be eligible for free or low-cost coverage through MassHealth or the Health Connector. The figure presented on this slide uses data from ASPE, the Office of the Assistant Secretary for Planning and Evaluation, and the Migration Policy Institute. To create this, we adapted an analysis that 2 really great Harvard Kennedy School students did for us. We're estimating that approximately 33% of the remaining uninsured in Massachusetts may be eligible for a subsidized qualified health plan, and 29% may be eligible for MassHealth coverage. Moving to the next slide, now we'll focus on current coverage trends.
Can you just pause? Can you go back?
Oh, definitely.
Go back. So this study is based upon income only, or does it also take into fact a person's residency status in the United States?
It's a rough estimate, that's for sure. It is based on income, though we used Migration Policy Institute estimates on the undocumented to see who may not be eligible for coverage, and broke out the undocumented folks in this analysis.
Undocumented 17%, 29% would be MassHealth eligible.
It's pretty consistent with like what we've seen in the DRR data for like 10 years.
10 years.
You know, which is about 60% of people, you know, if you make rough adjustments to estimate the undocumented, I mean, almost 2/3 of people report that their incomes are below 150% of
federal poverty level.
Yeah.
Yeah. Always, I mean, we have 2.2 million people on MassHealth now. Yep, it's just, I'm just always, thank you.
Yes, so kind of switching gears now from the remaining uninsured to current coverage trends in Massachusetts. We found that CCA'S most recent enrollment trends report, with data from March of this year, demonstrates a 1.5% increase in market-wide coverage since the start of the pandemic in March of 2020. That represents an addition of roughly 77,000 people to the Massachusetts market. In the figure here, you can see that this increase was largely driven by enrollment growth in Mass Health, but there were also shifts in the type of coverage people carried. During the same time period, you can see that employer-sponsored insurance, enrollment in employer-sponsored insurance and non-group coverage decreased. With more state residents covered now than ever before, the Commonwealth has an opportunity to preserve these gains and prevent people from falling into coverage gaps, especially as pandemic-related protections end and coverage sources begin to be redetermined. Moving to the next slide, mirroring market-wide trends, we looked at trends in the HICS and found that the HICS also experienced considerable applicant growth in both 2020 and 2021 relative to 2019. As in the broader market, beyond overall growth, there was a substantial shift towards Mass Health coverage, with 64% of HICS applicants qualifying for Mass Health in 2021, compared to 51% in 2019 and 57% in 2020. This trend is likely driven by a general reduction of income among state residents during the ongoing pandemic, as well as Medicaid protections associated with the federal public health emergency.
I mean, let's be clear, a big chunk of this is the fact that states cannot, the protections under the federal emergency does not preclude states from engaged in even minimal redetermination process. So yes, it is a combination, and that will probably not alleviate in terms of that process of commencing redeterminations again until the ending of the federal emergency, probably around April. So,
right. That is a valid point. And that being said, we think that the overall increase of people in the HICS will allow the state to maybe more easily support individuals in staying covered through this evolving economic environment, economic and policy environment. So that sort of covers on insurance and coverage trends. Before I move on to the next section, please let me know if I can answer any questions you might have.
What's going on with the health safety net, and how does, I mean, is there any data from that help to?
I don't have the data on me right now, but that is certainly something we can look into and get back to you on, Nancy. Okay, so maybe we can move on to outreach best practices now. So in addition to monitoring population level, market-wide, and HICS enrollment trends, the Health Connector uses a robust outreach strategy to deliver health insurance information to state residents in the most effective ways possible. In this section, I'm going to highlight the goals of Health Connector outreach, the strategies we use to get more residents covered, and talk through some of the limitations in our existing approach. So the Health Connector's outreach depends on 4 key inputs, including data and evidence to tailor approaches for various subpopulations, communications that are both culturally and linguistically inclusive, year-round touch points that sort of extend beyond our key business event, the open enrollment period, and partnerships with trusted community organizations like our Navigator grantees. Using these best practices, the Health Connector aims to help state residents get covered and stay covered so they can have the healthcare access and financial protection that health insurance affords. Beyond these individual level benefits, the impact of good outreach is expansive and can have positive long-term effects on markets more broadly. For example, there's some research that suggests that outreach tends to motivate younger people to enroll in coverage, which in turn can improve market stability with a more balanced risk pool. So I think a key question here is how, how we're employing these best practices and how we're measuring their impact. And while our staff continually seeks to quantify the reach and impact of our outreach work, it's been challenging to measure how well we're implementing each of these best practices beyond sort of tracking enrollment. And that's due to the complexity of the insurance market and its tight link to other intricate systems like the labor market. In the next slide, we sort of outline our data-driven and evidence-based strategies. Our outreach strategy has matured over time. We've sort of gone from generating population-wide awareness around the exchange to a more person-level targeted outreach strategy. So we use state demographic and geographic data about the uninsured to help staff tailor and prioritize outreach to specific geographies at the county, town, and zip code levels. And we also target outreach to subpopulations at higher risk for uninsurance, like those listed in the bar chart to the right of the slide. Additionally, the Health Connector regularly collaborates with and learns from academics and expert vendors to test, identify, and implement the most successful outreach strategies. So we use vendors like ASG to help saturate non-English language media outlets with simplified messaging to better reach residents of different racial and ethnic backgrounds. And we also conduct randomized evaluations of messaging and communications that allow staff to test how personalized information and streamlined enrollment pathways may motivate applicants to enroll in coverage. Moving on, working in concert with data and evidence, direct personalized consumer assistance from navigators and community-based organizations is a fundamental pillar of the Health Connector's outreach strategy. The Health Connector's Navigator grantees can be found in strategic locations across the state for easy access and for highest impact. Navigators speak multiple languages and meet residents where they live, work, get news, and spend time. As trusted members of their local communities, navigators provide year-round support to state residents, generating awareness, offering public education, and providing personalized application and enrollment assistance. Health Connector members who work with navigators report being highly satisfied with the experience. But that being said, not all Health Connector members seek navigator assistance. Lower income residents, residents from diverse racial and ethnic backgrounds, and residents with fluctuating eligibilities are most likely to work with NAVs. And then finally, here you'll see that since 2008, Massachusetts has led the country with a low uninsured rate, but in the past several years, the gap between the Commonwealth and other states has started to close. Even with outreach best practices and clear insight into who the uninsured are, the state's uninsured rate has leveled off. Though the Health Connector has taken a proactive approach to outreach, applying strategies that are responsive to changing population and market dynamics, there are certain inherent limitations to outreach to consider. I think I've mentioned this earlier in the presentation, but administrative obstacles to the application and enrollment process may discourage state residents who were otherwise motivated to obtain coverage. These administrative barriers may also cause inadvertent lapses in coverage as members transition between programs. Also, outreach strategies may not generate the same response in different areas with different subpopulations. I think I spent much of this presentation touting the benefits of data, and while it has certainly been helpful in directing and prioritizing our outreach, I think we know that people are far more complex than the zip codes in which they live and their demographic characteristics. Finally, effective paid outreach often requires significant financial investment,
which I believe we do. So I think we were good. Let's keep going here.
Okay.
I will pick up here. So just with an eye towards new tools that we feel like we can add to our toolbox in reaching the remaining uninsured, we're excited to share with the board that we have a new initiative launching this spring, thanks to legislative language included in the FY22 budget signed by the governor this past summer. We want to express our deep thanks to EHS and A&F and the governor's office and the Department of Revenue and the legislature for their partnership and support on this legislative change that was needed to position the Health Connector to conduct the new work we're about to describe. As the board may recall, staff had long-standing interest in being able to leverage the process by which uninsured tax filers report on their state income tax forms that they are uninsured for the purposes of the individual mandate, and utilize the information to help people understand specifically what they might be eligible for and get them into coverage. The new legislative authority granted to us to make this linkage upon tax filer consent is a significant step forward for our ability to engage directly with uninsured residents. We'll walk you through some high-level updates on the initiative's goals and the status of our implementation efforts. At a high level, the goals of the project are, of course, to increase insurance coverage in the state. We don't yet know how many of the roughly 300,000 tax filers who report at least partial year on insurance each year will check the box, consenting to have their information shared with the connector, but we estimate it could be up to about 60,000. Another goal of the project is to allow the connector's work to reach and speak to the uninsured, to move from being solely reliant on community level communications where, for example, we push broad messages in particular communities, to newly allowing us to directly communicate with people reporting to the state that they're uninsured and want help. This change lets the individual mandate reporting process that's been in place for about 15 years to evolve from being just about compliance data and assessing whether a tax penalty is owed to being usable for directly responding to the very people we're trying hardest to find and assist. Lastly, we see this project as an opportunity to strengthen our own ability to see the extent to which the uninsured in the state may already have applications or accounts in the HICS system, which will be helpful for us understanding how people come and go out of coverage or inadvertently lose coverage they've taken steps to get into. And will improve our overall line of sight into the uninsured generally. So just to give you a sense of how this new capability to check a box, consenting for information to be shared with the connector will look to the public, you can see here a new box that our colleagues at DOR have added to the 2021 tax form that people will start to file in the new year. When an uninsured tax filer checks this box, authorizing DOR to share information from the tax return with the Health Connector for the purposes of assessing eligibility for health coverage, DOR will transmit the authorized data to the Health Connector. This will set in motion the ability for the connector to reach out to the individual with preliminary information about what they may qualify for, how to apply, and make them aware of local resources in their community that can assist them getting into coverage. To share more on the implementation process we're engaged in to bring this initiative to life, I'll hand it over to Marissa to briefly describe and also to touch on a few other areas quickly of staff exploration in the way of new approaches for reducing uninsurance, and then wrap us up.
Hi, Audrey, quick question for you.
Oh, sure, yes.
Was there a reason why we are asking these folks to opt in as opposed to asking them to opt out, given the fact that data has shown if they're being asked to opt out, we'll probably get larger participation?
Mitri, I think the overall issue is largely one of high sensitivity regarding tax information, and we really want to respect kind of the ability for taxpayers to say, yes, I want this information, so that they don't feel that other agencies are sending them information without specific requests.
Thank you, Louis.
Okay. So as Audrey mentioned, we've been working closely with DOR since July to ensure we're ready to help people get covered this spring. Over the summer, we began working on the nuts and bolts of the data sharing agreement and the technical specifications of the data transfer. And this fall, we've spent a lot of time internally working on what the communications plan will be, both to taxpayers who ask for help, as well as at a higher level tax preparers who will be an important partners in this process. We hope to educate them that this is a fast and easy component of the tax preparation process, and to provide them with some talking points they can use to help explain to their clients why to check the box and what to expect if they do. We expect to start receiving data as DOR begins processing returns, probably in the late February timeframe. We'll begin monitoring use of the checkbox and the associated eligibility and enrollment outcomes throughout the spring and summer, and plan to report back with results in the fall. As we've been thinking about our outreach approach, we've looked to research on this topic so that we can be as effective as possible. First, we know that the more personalized this outreach can be, the better. This was a learning from our outreach experiment we conducted a few years ago among individuals eligible for but not enrolled in Connector Care. Preliminary findings showed increasing enrollment rates as the specificity of the mailer increased. And a similar experiment conducted by the IRS showed that a letter with tailored information on federal individual mandate penalties was more successful at prompting enrollment than a generic one. Secondly, we plan to provide contact information for local navigators so that individuals can more easily connect with nearby in-person support if they'd like, based on similar success in Pennsylvania's Supplemental Nutritional Assistance Program, or SNAP. And finally, we're exploring how live outbound calling could be helpful in this effort, though of course the volume of requests as well as the volume of inbound calls would dictate whether this would be a viable option to us. Through this process, we're mindful that many people are hesitant about data sharing, and we want to make sure that individuals feel secure in checking the box that the Health Connector will be getting kind of just enough information. And we'll be focusing on providing the application and enrollment assistance that was requested. In addition to technical infrastructure that will keep data secure and available to the minimum number of staff, we're also planning to provide an opt-out pathway and to limit the use of data in subsequent tax years.
Great.
If no other questions on simple sign up, I can move on to kind of a step beyond that. Beyond just assistance, and
let's just pause. Are any questions? Trying to look up and down. Nancy,
allowed to like exclaim in excitement that we're moving in this direction. I mean, that's a wonderful development. So kudos to everybody who's involved in getting that.
This is really so on the Mass Health side, and a similar is finally, and I'm going to put like finally, we have done a similar fix on what some people know as the SNAP gap. So that if you, it's not till July, but you apply for Mass Health, check a box, and the data would be automatically, your information would be automatically through a secure portal to DTA to basically populate the application. Still requires the interview because that's a federal requirement, but you know, it's not that sort of having to, it simplifies the process. So yeah, it's amazing.
I mean, I think having information on the names and addresses of people who don't have coverage and just sitting there is, so this is just a really, really exciting development.
Yeah, it is. So thank you for this. Go, keep going. Sorry.
Thank you. So we've also been exploring automatic enrollment into connector plans for individuals who qualify for a no-cost plan, as Nelson mentioned earlier. Many individuals facing coverage transitions have competing priorities for their attention, such as a job change or job loss, that make finding time to enroll challenging. Extensive research has documented the so-called time tax on lower income populations, who are also the most likely to be uninsured. That requires them to spend a lot of time and energy proving that they qualify for programs designed to support them, and often resulting in individuals who abandon the process. And as noted in our equity presentation, these burdens and barriers fall disproportionately on people of color. Studies of various automatic enrollment efforts ranging from Medicare Part B and Medicaid to 401k participation demonstrate positive impacts of automatic enrollment on the participation by eligible individuals. Individuals coming to the Health Connector may be more familiar with more streamlined enrollment processes for health coverage, such as in Medicaid or employer-based coverage, and they may not realize that they need to take an extra step after their eligibility is determined to select and enroll in their plan, leaving them inadvertently without coverage. A variety of models thinking through how to do this in an exchange setting have been posed in recent years, some of which suggest using tax filing data to identify individuals who would qualify for free coverage under the ACA, while others target specific populations, such as individuals losing Medicaid coverage. And we also have a model in our pre-ACA program, Commonwealth Care, which used automatic enrollment successfully for several years which I can go into on the next slide. So the Commonwealth Care approach to auto enrollment focused on existing applicants. So it was a bit more contained than some of those other recent proposals I mentioned. Economic researchers recently explored the impact of automatic enrollment in Commonwealth Care and found that it increased enrollment by 30 to 50% among those who are eligible for $0 plans. And those enrollees were disproportionately younger and had lower risk than active enrollees. In the first year of their coverage, those auto enrollees had 44% lower health costs than active enrollees. And importantly, the researchers were able to look at what happened when we stopped doing auto enrollment in 2010 and concluded that the population that was auto enrolled wasn't enrolling otherwise. There was no increase in active enrollments when that policy changed. And so we've been reviewing this model closely in today's coverage framework, as it's a little bit different under the Affordable Care Act, particularly paying close attention to the tax implications of auto enrolling someone when there are advanced premium tax credits involved. Any questions on that component?
No, it's again, it's great. I mean, we have more and more evidence and more social programs that doing auto enrollment, I mean, even in private, pensions and other things, savings accounts. So this is great.
Okay. So finally, and Nelson alluded to this earlier as well, we've been working to identify areas where members and applicants tend to get stuck and then see what flexibility we have to change our policies or processes and make keeping coverage easier for them. For example, we've heard that some applicants are confused about how to verify their income, especially given inconsistent work or transitions to self-employment or retirement income that many individuals have had over the last 2 years. So we're currently looking at guidance that we can provide to help people understand what's required, looking at additional document types that people could use as proof where we have flexibility to expand that. And we're also looking at federal flexibility that's available to us that would allow us to validate someone's attested income with IRS or DOR data in more circumstances. So kind of doing that work up front with the data that we have rather than asking them to send proof, which would kind of nip that in the bud further upstream. So we're really pleased to share this update with you today, outlining our ongoing work to increase insurance coverage in Massachusetts, work that has solid footing in the outreach and policy work that we've been doing for the last 15 years and that we are excited to continue to refine. We'll be sure to apprise the board and the public about our progress and learnings and the results of some of these approaches, and we continue to welcome dialogue and on additional tools that we can use to ensure all residents are covered in accordance with our strategic plan and our broader mission overall. Any other questions?
Marissa, can I ask you one question? I know some states are looking into using different types of federal waivers to get permission to allow populations who otherwise might not be eligible to enroll, certain groups of non-citizens. For example, I think Colorado's doing something. There might be something else. Is that on the list of things we're exploring too?
I think I've heard a little bit about those, but I don't know exactly what design details they have involved, but it's something we can look into in more detail.
Yeah, I mean, I don't know much more about them either than what I just said from sort of reading some of the news clips, but I would love it if we could see what kinds of things, particularly for those groups of people who have disproportionate rates of uninsured, we might, learn from what other states are doing there too.
Any other comments? Good stuff. Really. We're back. Back to being like the Brady Bunch here. All right, so there's a lot. I'm going to turn it back to Louis and to wrap this up. This is like a big agenda. It's the right agenda. It's a big agenda going forward. But mean,
It really is, in particular, in light of the unwinding this next year. That's going to be a very big operation for both Mass Health and Connector, and we look forward to doing it well. But I want to thank the policy team as well as our operations unit for really signing up for not only getting the DOR thing immediately underway, but a broader agenda on equity and automatic enrollment.
Just your kind of meeting, Louis, lots of policy.
Nancy, we hadn't forgotten. I remember when you said, you know, we're like awfully operational, which we needed to be for, right?
Yeah.
I was thinking that too, you know, 2015, when most of the meeting was like, wow, how are we digging out?
Well, this is great. So, you know, the digging out and the operational is obviously very important to our members, and this is important too. So we appreciate how you all are able to juggle so many different things.
Well, it allows you, by having the infrastructure and the operations in, you know, a good place, even with the lumps and bumps of the recent call center, right? It really allows then the ability to move in the policy agenda. And I also do want to comment, because I do remember the early 2015 days of just the strong working relationship of the Connector and the Mass Health team. And I mean, it's very fluid, and that allows then the HICS systems, not just the stability of it, but to be able to then utilize it for additional technology adjustments that really can have some significant impact on people's lives and their ability to get benefits. So, I mean, that's sort of where I sit, you know, when I think about the trajectory of some of this. So, I just want to extend my appreciation to all the staff of the Connector, and under the leadership of Louis, and to the board for your, for keeping the Connector really focused on the customer service, the equity, affordability. You know, it's been a completely challenging 20+ months or whatever, but if I just think about this past year, you know, the Connector's strong because of leadership and management, the operations, the policy, but it's really also because of the steady hand and the focus of the board. So I appreciate it. And I know I've not been as present this past year as in prior years. So thank goodness for that vice chair.
Glad he's not here.
I don't think anything prepared you for something that hasn't happened in 100 years, Secretary. So I think
I don't think anyone was prepared. So
no,
I stand on the shoulders of many.
Thank you, Secretary. And I would just reiterate my thanks to the board, which has been with us through thick and thin.
You see the progress. Okay. All right. Is there any other business before the board? Did I miss any hands or claps there? I do look forward to the day where I can unzoom, you know, but it's good to be physically present again with one another. Okay. Hearing none. Is there a motion to adjourn?
So moved.
Is there a second?
Second.
Do we have a final roll call of 2021 here? Kathy, I don't think we have any more board meetings between now and the end of the calendar year.
We do not. Okay, so we ready? Gary?
Yes.
Mark?
yes.
Cassandra?
Yes.
Dimitri?
Yes.
Secretary?
Yes.
Nancy?
With holiday wishes to you, Kathy. Yes.
Thank you so much. Matt?
Yes.
Rena?
Yes.
Thank you, everyone, and happy holidays.
Happy holidays, everybody.
Happy
Be well.
holidays,
Take
everyone.
care and get
See you all
boosted.
next year.